think everybody's here. I'm Dr. Balada. I'm pleased to introduce Danielle Becker. She's Associate Professor of Clinical Neurology and Director of Epilepsy at Case Western. She completed her medical school at the University of Miami and also completed 2 years of fellowship in University of Pennsylvania and NYU. Has a special interest in women epilepsy and surgical evaluation of patients. So I will let her get started and talk about the need for seizure control in epilepsy.
Thank you very much, and thank you for having me today. I know that there's a lot of fellows there, so I try to keep this interactive. So please, if you have any questions, feel free actually just to speak up since you can't really raise your hand. And at the end, I'll try to make it a little bit more interactive as well. I just want to make sure everyone can hear me okay and that the volume, everything's fine. Great.
Yes, we can.
My clinic is in the basement, well, not the basement, but the bottom floor near some MRI machines. So sometimes the signal is not the best. So today we're going to talk about epilepsy, basically the unmet need and persistent need for seizure control. So this is an SK Life Science sponsored program. So FDA promotional rules will apply. So today we're going to talk about epilepsy epidemiology and risk factors, differing perceptions of seizure freedom, what a perception is maybe by providers, showing that there's actually different perceptions among many providers, as well as patients. Talking about the impact of continued seizures, current treatment options, talking about healthcare provider approaches, and also how we can overall try to improve patient outcomes and patient education. So as we know, I'm going to actually move this, you guys, make sure you guys. So as we know, epilepsy is defined, basically we kind of have two definitions. The old definition that we had was that you'd have to have at least 2 unprovoked, or they'll call them reflex seizures, occurring greater than 24 hours apart. And then a newer definition came out several years ago that said, okay, you can have 1 unprovoked seizure, again, or reflex seizure, and then something else that shows that there is an increased probability to have another seizure. So for example, if there's an abnormal MRI that shows a structural abnormality, or if there's an abnormal EEG, then that suggests that the person has a predisposition to have another seizure. So a recurrence risk of at least 60% over the next 10 years. So if that's the case, then at that point, after just 1 unprovoked seizure with a abnormal MRI or EEG, they would be considered to have the diagnosis of epilepsy. So the International League Against Epilepsy in 2017 actually revamped our seizure classification, ideally to make it easier both for the providers and the patients. So they tried to clean it up in the sense that they tried to define it a little bit more clearly and also have definitions that we are using across the board, so both clinically and in research, so that it reduces confusion. And so you can see here that they've broken it up into focal onset seizures, generalized onset seizures, or unknown onset. And it's thought that about 60% of our population consists of focal onset seizures, 30% generalized onset seizures, and then about 10% might be that unknown onset where, all you know is that they had a convulsion, you don't know if it started focal or generalized, or maybe even a mixed. And then when you break down focal onset seizures, it breaks down to either awareness or impaired awareness. So we call it either focal aware seizures, FAS, or FIAS, focal impaired awareness seizures. And then that is actually further subclassified into either motor or non-motor. So you can see that here. And we do know that patients can go from focal to bilateral tonic-clonic. So that is the new wording that we use instead of secondarily generalized. Then for generalized onset, which consists, as I said, of about 30% of our population, if a patient has generalized onset, they have impaired awareness. It is not possible to have a generalized seizure with maintained awareness. Again, broken down into motor, as you can see here, and non-motor. And then lastly, the unknown onset is also broken into motor and non-motor, or unclassified. So now, in kind of talking about provoked and unprovoked, and I'm going to explain this slide a little bit differently because I think it's slightly confusing. But the thought is that if something is unprovoked, it basically occurs in the absence of a temporary or reversible factor. And so the thought is that if there's something that is kind of reversible, like sleep deprivation or stress or something like that, that it still can essentially be an unprovoked seizure, because in our minds, you can't really eliminate that. And so the thought is that yes, that can lower the seizure threshold, and that can, possibly make it easier for the patient to have a seizure, but you're not going to be able to reduce stress, all stress in people's lives. You're not going to be able to make sure that they're never going to be sleep deprived. But the thought is that would be kind of an unprovoked seizure. A provoked seizure, which people kind of refer to as reactive or acute symptomatic, that's when there's something that actually happens on an otherwise normal brain to temporarily lower the seizure threshold. So, for example, if someone has a concussion, it's considered provoked. If it's in the setting of a fever, like these things are going to go away and ideally would not recur. Alcohol withdrawal. And so the thought is that is a provoked seizure, and a provoked seizure does not necessarily mean that the patient has epilepsy. The International League Against Epilepsy defined refractory epilepsy. And so what we say is that if a patient has drug-resistant epilepsy, if they have failed 2 or more medications at adequate doses, and these are medications that were appropriately chosen to treat the type of seizures the patient has, and they continue to have seizures, then they have met the definition of refractory epilepsy. And what it's thought is, and we'll go through the Quan and Brody studies, it's thought is that if a patient has tried 2 or more medications at adequate doses and failed them, meaning they continue to have seizures, then the likelihood of a 3rd, 4th, 5th medication controlling seizures is less than 5%. And that is why they are thought to have this definition of refractory epilepsy. And the thought is by saying 2 or more medications that ideally we will identify them as having refractory epilepsy earlier, and if they need to be referred for surgery, that they may get referred earlier. Because as of right now, we know that the amount of time on average it can take to get a patient to surgery is almost 20 years. And I think that's gotten better over the past couple of years, but that's still the statistic that's out there. The other thing is I do think that there may be a couple of medications that may kind of redefine that Quan and Brody paper of, saying that it's less than 5%. So the other thing is to kind of decide, are you going to change to another medication, or are you going to refer them to surgery, or what is the patient amenable to? So we know that epilepsy affects a large number of people across the world. So 65 million people worldwide suffer from epilepsy. And when you're looking at just the United States, we know that 3.4 million people in the U.S. have epilepsy. And of those people, it's important to know that there's still about 150,000 new cases per year. And then, depending if you focus on adults or children, we know that about 85% of epilepsy cases are in adults and about 15% in children. I apologize for being stuffed up if some of you are on. My daughter just started school and is bringing runny noses home. So to keep going, so what have we seen in our epilepsy treatments over the years? So we know that we have 34 medications to choose from. And we know that multiple medications have come on the market, even in the past 20 years. But if you look at studies that were done in 1997 and studies done in 2014, and if you look at that orange, which is thought to be seizure-free with, initial monotherapy, or if you actually just look at the gray, which is not seizure-free, you can see that despite all of the newer medications that have come on the market, the same amount of patients, which is about a third, remain to continue to have seizures. And so the thought is that even though more and more medications have come on the market, we really have not moved the bar. We still have the same amount of patients who are refractory. And that's a problem. Ideally, we want to try to get better at what we're doing and try to reduce the seizures and potentially increase a larger amount of patients who are seizure-free. And this is also a graph just to show you that we know that the most common times to get diagnosed with epilepsy is bimodal. So it's either young, thought to be, up to, before age 20 or after age 65. And the young is really more kind of infancy related to neonatal or infant perinatal, prenatal injury, and then the 65 and greater sometimes is related to cerebrovascular accidents, tumors, TBIs, things like that that make it bimodal. So we do know that the majority of the time the etiology of epilepsy is unknown. So 65% of the time we will not have an answer. And we know that even when we're seeing patients in clinic and they will say, well, why do I have this? And unfortunately, we don't always know. We do know in children, so about maybe 8% of that first mode of when epilepsy develops early on could be congenital. We also know that vascular, as I mentioned, as people get older, degenerative as people get older, trauma as people get older. But there's also tumors, there's also infections. But again, a lot of the times we may not have an answer. And we also know that there's a significant mortality associated with epilepsy. So what a lot of people don't know, and I don't think I actually knew until starting to give this talk, was that epilepsy actually takes more lives than breast cancer. I mean, it's close. It's about 45 to 50,000 versus 41,000 lives annually. But the point is that epilepsy is very prevalent, and a lot of people do not realize that. Also, every hour, 5 people will die of some epilepsy-related cause. And lastly, if there are uncontrolled seizures, so essentially if they have refractory epilepsy, they have up to a 10 times increased risk of premature death. And so that kind of brings us to life lost due to epilepsy. It really focuses on epilepsy-related deaths as well as SUDEP, which is sudden unexpected death in epilepsy. And we know that this accounts for over 100,000 years of potential life lost. And what's even harder is that, especially with SUDEP or epilepsy-related deaths, they can happen early on in life so that you are having potential life lost because of this disorder and its related deaths. To kind of go further into the definition of SUDEP, we know it's death in a patient with epilepsy that is not associated with trauma, drowning, status epilepticus, or any known cause, with or without evidence of associated seizure. So it basically means that someone with epilepsy has died and we don't know the cause of it. So definite would be that it meets clinical criteria and that autopsy reveals that there's no alternative cause of death. Probable means that they meet clinical criteria, but that there was no autopsy that is conducted. And possible is when you're just basically really not sure. But clinical data are really lacking. You don't know what really happened, and there could be an alternative cause of death. The majority of SUDEP cases occur typically during or immediately after a seizure. Does not have to be the case. I had a patient, unfortunately, who had an RNS device and ended up passing on, I think it was on February 13th, a couple of years ago. And looking at her RNS data, her last seizure was actually on February 8th. And so there's other things that they thought, but so she did not pass because of the seizure. We also know that epilepsy is associated with many comorbidities. So we know stroke, heart disease, asthma, social phobia, but we also know in the mix is mood disorders. In fact, I think at least 30% of our patients will have that. Learning disabilities, ADHD, other things as well. And we know that epilepsy leads to increased healthcare as well. So $15.5 billion is related to direct medical and indirect costs due to loss of basically earning and productivity per year, as well as ER visits. And so we know that annually per person with epilepsy, so each person with epilepsy is going to cost somewhere between $1,000 and $20,000. And that was only in 2013 that was published. And we know that there's an average of 1 million emergency department visits per year. So now let's move forward and just kind of think about what we can talk about and what we should focus on to really try to help improve our patients. And the first thing is trying to figure out who has continued to have seizures and how many patients do we expect to become seizure-free, and what is the expectation, and especially when we sit down and talk with our patients. So we know that there was a study, this was actually in 2018, but this is also done by Kwan and Brody. They're the second and senior author on these papers. And here, it was basically a revisit of the Kwan and Brody multiple years ago, again, showing that after being on 2 medications at adequate doses, if you haven't become seizure-free, the likelihood that you're going to is going to be less than 5%, and that's about 36% of our population. However, there was also a CDC study that was recently published in 2018, and what they did was it was actually a door-to-door survey where they went to door-to-door and basically asked people if they were having seizures and if they were on medication. And there, they had a report that 65 to 70% of patients continued to have seizures. Now this one, I think the quantibrodium might be a little bit of an underestimation, and I think that the CDC might be a little bit of an overestimation, because they were going door to door. They didn't know if patients definitely had seizures. They didn't know if they were being treated correctly. And I think it's probably somewhere between 40 to 50% of patients may continue to have seizures despite being on medications. And then this particular graph is just kind of showing when patients don't have seizures, there really isn't a differentiation of whether they're seeing specialists or not. But if they do have seizures, they typically, more of them will be seeing a specialist. So the survey was based on healthcare providers, and what they kind of found, another survey that was actually done in 2018, is they actually thought that when you talk to providers about if patients actually are seizure-free, that providers are basically giving an overestimate. So providers were saying 80 to 88% of patients were seizure-free, that only 20% or less were continuing to have seizures. And the seizure freedom, depends on what the definition is, but the agreed upon definition of seizure freedom is 0 seizures in 12 months. We're going to continue, and we'll go on through other questions because I want to kind of just open it at the end to questions. But what I really want you to think about is, what is your definition of seizure freedom? Is it that a patient is seizure-free for at least 12 months? And do you have a difference when you define seizure freedom versus seizure control? Can you guys hear me? I think the internet cut out.
We lost about 2 minutes, I think.
2 minutes? Okay. I apologize. Let me go back. Did you guys hear this whole slide?
We were in the middle of the previous slide.
Okay. Can you see my slides right now or no?
No.
Okay, hold on. Let me Okay, is this the slide I was on when you guys lost me?
I cannot see any slides right now.
Oh, you still can't see it? It says
that was the one. That was the slide.
Okay, so you can see it. Okay.
Yes.
Okay. Did you guys hear any of this slide? Now I can kind of start over. So with this slide, so everybody can hear me and see the slides now, fine. Okay. Okay, with this slide, I'll kind of start over because I think it's important, especially for fellows. Let me just make sure. All right, good. So what I said was these are kind of the things that we can think about. So how do you as a provider define seizure freedom? And does that differ from seizure control? And so if someone is having, one seizure a year, or if someone's having, focal aware seizures, does that mean that you think that they're seizure controlled, but they are not seizure free? And is there a difference in definition, and is there a difference in what you would treat? And then we already went through why the CDC and Quan and Brody studies are a little bit different. And then lastly is kind of how do you discuss treatment goals with your patients? And it's important to note that patients may have different treatment goals than the providers. And so it's important to ask because you want to make sure that you're on the same page. And a patient might say, I want to be completely seizure free, or is seizure freedom or seizure control when you don't have any generalized tonic-clonic seizures. Or a patient might say, listen, I want to drive, so whatever you can do to help me drive. And so you want to know what those target goals are. Okay, can everyone hear me okay? I just want to make sure as I go on.
Yes, we can hear you well.
Okay, good. Thank you. All right, so what I was saying is that, so we know that there are inconsistent definitions of seizure freedom. So in a single center in Scotland on epilepsy, and this is really kind of looking at the Quan and Brody study. And so basically what they said is that people were considered to be seizure free if they had not had any seizures of any type for a minimum of 1 year, receiving the same dose of anti-epileptic medication. And then there was another study that basically defined poor seizure control as having or experiencing 5 or more seizures in the past 12 months. And then another study, a recent National Health Interview study, defined seizure control as no seizures. And so what I don't know if you guys heard or not is that really, I think, is seizure control seizure freedom? And does it change depending if you're talking to the provider or the patient? So based on a survey, the definitions of seizure control by HCPs varies. And so I'm going to explain this slide to you because it might be a little confusing. But what we see is that essentially these numbers are saying, okay, how many providers thought that this was patients controlled versus uncontrolled? And so if a patient was averaging 1 to 12 seizures a year, you can see that 63% of providers, and these are advanced practice providers, physicians, so it's a combination of a lot of people. And what they saw was that even if someone is having potentially up to 12 seizures a year, 63% of the responders thought that was controlled. And then you can see as the number goes up more, so 13 to 24, 25 to 48, or more than 48, then people tend to really say they're uncontrolled. But if you look here, 13 to 24, half of the responders are still saying that's controlled. So again, it makes you think, what is controlled? Is controlled seizure free? And, what is the target of treatment? And so if they are controlled but continuing to have seizures, what is that impact of seizures? And so we know that there's a burden of epilepsy that can be significant for patients and for caregivers. So, if patients continue to have seizures and or continue on seizure medication, they may have sexual dysfunction or infertility. We know if people continue to have seizures, even one or two a year, there might be employment restrictions. They potentially have the risk of status or sudden unexpected death in epilepsy. They might get injured from their seizures. They may have difficulty with emotional and social relationships. They may feel very isolated. There's an increased cost to the patient and the healthcare system. There are cognitive issues. And then, their ability that they might not be able to drive, or if they did drive, they could have gotten into accidents. So there's a lot of factors that play a role into a significant, even emotional burden for people and their caregivers of people living with epilepsy. And so when epilepsy patients were asked, what is most concerning to you about having epilepsy, you can see here that the majority of patients actually said driving. That driving was one of the biggest things that they were worried about or concerned about, especially if they couldn't drive. And then right underneath that is employment and independence. And you can see that is actually more of a concern to them than medication side effects and seizure unpredictability. And here you can see that seizures really reduce the quality of life in our patients. So here you can see kind of seizure-free versus seizures. And so, 81% of people with seizures, I mean, it should be 100 people with seizures, but basically can't drive. And have greater limitations in employment, almost twice the amount of limitations in employment, and almost twice the amount of limitations in education. And so you really can see that it affects all aspects of their life. And so even one seizure in the past 5 years can impact a patient's life. So this was a study that was done in 2017 by Joseph's son, and you can see that patients with one or more seizures in the past 5 years versus patients who were seizure-free, so patients with even one seizure, showed that they were 3 times more likely to have poor health, to experience stigma, 6 times more likely to have depression, 4 times more likely to have overall life limitations, employment limitations, prevention from driving, so we just talked about that, 4.5 times more likely to not be able to drive, 2 times more likely to have limitations in education, and also to experience avoidance and isolation. And so this is another study that was done in 2019, polling patients. And basically 80% of the patients that they polled said they felt some sort of isolation. 75% were afraid or lived in fear of when this next seizure might come. Many felt trapped and powerless, and many believed that epilepsy was a burden and chronic and would never go away. And you can see some quotes here and really, see how really affect your patients. So I'm not a monster. I'm scared at any moment that I may have a seizure. I can't do anything on my own anymore, or I just want to feel normal. So I think that these quotes really hit home of what our patients are experiencing, and especially our patients who continue to have seizures. And so what are the treatment options? So we know that there are multiple different drugs on the market right now. And I said it's about 34 drugs. And so here you can see many of them listed. You can see they have many different mechanisms of action, ranging from sodium channel blockers, calcium channel blockers, GABA-related enhancements, glutamate antagonists, synaptic vessel protein, drugs that work on the synaptic vessel protein and don't allow glutamate to be released, and other mechanisms of action that potentially might be unknown. We also know that if patients fail medications, the other kind of non-pharmacological treatments that are available are surgery, resection, laser therapy, corpus callosotomy, hemispherectomies, also neuromodulation. The 3 FDA-approved neuromodulation devices include deep brain stimulation, responsive neurostimulation, and vagus nerve stimulation. Also, the ketogenic diet or modified Atkins diet are dietary approaches that patients can take. And what we've seen is, so this is looking at patients experiencing a greater than 50% reduction in focal seizures with adjunctive anti-epileptic drug studies. So you can see here that a ton of the medications are listed, and they actually are listed of when they first came on board. And I didn't know, but actually zonisamide was used in China in the 1990s. So that actually surprised me when I was going through the information for this lecture. But basically, you can see that as far as the amount of patients who are having a greater than 50% reduction in seizures is only about 40 to 50% of patients. So we're really only getting half of our patients, moderately controlled. And so, again, that speaks to, well, what else can we do? And when you actually think about seizure freedom, which, may be the goal of the provider and or the patient, how many of these drugs actually have the potential to make someone seizure free? And you can see here that it's pretty low. So these are the percent of patients who achieve seizure freedom. And you can see that, levetiracetam or Keppra actually probably had the best results, and that was at 6.5% seizure freedom in these clinical trials. And so what do? So we have all these medications. We have, maybe, 6% that we're going to get seizure free with, at least in clinical trials with refractory patients. I should step back. Those clinical trials were in patients with refractory epilepsy. So when you look at the Quantum Brody study, the first drug, second drug, you still are going to get about 67% of patients seizure free. What I was just showing you was refractory patients that continue to have seizures. In a lot of those clinical trials, they may have anywhere, from 5 to 9 seizures a month. So what do we do for those refractory patients? What's an approach that is acceptable? So when do we start therapy? That is a key question. So if a patient has one seizure, first time seizure, it's unprovoked, what do we do? Do we start medication right away? And so we've actually seen that immediate therapy after the first unprovoked seizure does reduce the risk of subsequent seizures within 2 years by 35%. So it does potentially reduce the risk of injury from a seizure. However, it is unlikely to improve the chance of sustained seizure remission over the long term. So regardless if you start meds right away or you wait until the second seizure, it's not going to change their chance of seizure freedom. And you really need to think about risk stratification, because when you start an anti-seizure medication, it's not without complications. So patients may have drug side effects. So it may still affect their quality of life. And that's why you really need to balance the decision and have a discussion with the patients, again, of what is their goal. If they say, I never want to have another seizure ever again, I'll take the chance of side effects, versus someone might say, I only had one, it was in the setting of maybe, sleep deprivation. I don't want to be on a medication for the rest of my life. Let me see if I have a second one, do I have an increased risk? And what I didn't go into is that 10% of the population in the United States may have a one-time seizure. And of that 10%, only about 30% will go on to have epilepsy or recurrent seizures. So you have 70% of patients who may not need the medication and may never have another seizure again. So that's really why you need to have this discussion. So, but if you have more than one unprovoked seizure, then that does require treatment, because the thought is that they have a higher than a 60% chance of recurrent seizures in the next 10 years. And Anne actually just put forth guidelines on the approach to kind of time to refer patients. So if seizures are not controlled and there is diagnostic uncertainty of treatment failure in children, young people, adults, they should be referred to tertiary services, ideally sooner than later, for further assessment. And referral should be considered when one or more of the following criteria are present. If the epilepsy is not controlled with medication within 2 years, if the management with medication is unsuccessful after 2 drugs in adequate doses that are appropriate for the patient, if there's a unilateral structural lesion, and if there's any, psychological or psychiatric comorbidity, which we see in our patients, and if there's a diagnostic doubt as to the nature of seizures or seizure syndrome, you should ideally refer them to a tertiary center or a specialist. And that brings up kind of the discussion is, what do we talk to our patients about? What do the conversations look like? And how do we improve the conversations and communication? That takes us to our last few slides. So this is kind of examining the conversation between epilepsy patients and healthcare providers. And so there was a study that was done in 2018. And we take this study with a grain of salt, but this study actually published that the mean duration of patient visits was 7 minutes. Now, if you ever see patients with epilepsy, you think, oh my God, there's no way that I only spend 7 minutes with these patients. But this is at least what the study had shown. And, maybe it was patients that were well controlled. I mean, that's what's kind of hard to know about the study. And so really the take home message for this study is just that it makes you stop and think more than, are people really, talking to patients in only 7 minutes? And if that's the case, what are they missing? And so what was also kind of found with this study is that patients were not necessarily being upfront about their seizure freedom. So they might have said like, oh, I know I haven't had any seizures. And, that was it, and nothing further was asked. Descriptions weren't asked of, okay, well, have you ever had deja vu? Have you ever had a metallic taste in your mouth? Do you get a flutter in your stomach? Because some people don't realize, some people think the only seizure that they know is a generalized tonic-clonic seizure. And they do not realize that other events, our seizures, can present differently. And so there's many people that don't actually know what a seizure is or can be. Patients also sometimes are hesitant to switch medications, so they may not say anything. Healthcare providers thus need to probe and uncover symptoms, uncover side effects. They need to ask about side effects because patients may not volunteer it. We know that HCPs often may discuss side effects, but not necessarily potential benefits of a new medication. So someone might say, oh, I'm really tired, or oh, I have stomach upset, or I feel dizzy. And we might just say, oh, well, try to take it at bedtime or try to take it with food. But we may not say, well, there's a newer medication that might have less side effects. And again, this is some people, this isn't everyone. It's just really brought up to bring up conversation more than anything else. And HCPs rarely, again, according to the survey, so take it with a grain of salt, but rarely offer multiple medication options. They don't typically define what seizure control is or the distinction between good and poor control. And they don't necessarily ask patients, what does control mean to them? What are the patient's goals? And so the conclusion of this study was that really there needed to be an improvement with shared decision making to effectively manage epilepsy. And another study actually looked at research of what do patients and caregivers want. And what they found is that on average, what was stated was that the patients want to be heard. They want to have ample time with their provider. They want their provider to listen and emphasize, and also offer practical advice. And they also want to plan together. They want their goals to be included. They don't want to be told, I'm going to be on this drug with this side effects and not be given any other options. So there was a tool that was developed. It's called STEPS. And I'll talk about what that means. But basically, this was a tool that potentially could be given while patients are in the waiting room or could be sent to patients before their visit. And what it is it's meant to basically improve communication and have the patients kind of go through what's important to them. And also help discover if a patient's having seizures or not and identify other comorbidities. So the STEPS stands for, it actually spells out. So S is for seizures. So you can see in the top kind of column or row, there's characteristics asking the patient to describe their seizure activity. The next is treatments. It's talking about whether the patient is compliant, whether they have side effects, what if they're not compliant, why. E is for emotional impact, so it's asking questions about depression, anxiety, mood issues. P is for personal goals, so what is the patient's goal? What's their goal of the visit? What's their goal over the next year? And then the S is kind of for safety and also for SUDEP as well. So discussing safety risks or risks of increased death. And so the thought is that, when the patient comes into the office, first and foremost, you find out if they're having seizures or not. You find out if they've had any injuries, any hospitalizations. And then you look potentially at this form and you make sure, you might not be able to go through all of it, but you can look at what the personal goals are or what their safety concerns are and make sure that some of that is addressed. And if you can't address all of it, you have it to address at the next visit as well. Or it lets you know that, okay, there's a lot of things going on. I might not be able to address them all today, but I'm going to have you come back sooner, maybe in a month or 2 months. And so, the question is how do we address these, communication disconnects between patients and caregivers? And how can we make our office visits more effective, especially given our limited time? And how can we make patients feel heard? Which I think is very difficult. And, with patients with epilepsy, there might be a lot going on. And to try to get through all of that in a half hour can be very hard. But how can we at least make sure that we are hearing, the goals or the things that are most important to our patients? So in conclusion, a significant number of patients continue to have seizures despite the introduction of multiple new therapies over the past 20 years. They've continued to have seizures that impact their quality of life, employment, emotional status, driving. And there is an opportunity for better dialogue between patients and healthcare providers and to really align with the patient's goals. So, while we may not be able to, move the needle as far as refractory patients, although we're going to try, and new medications are coming out. Some have come out this past year. But what can we do right now? So if a patient doesn't necessarily want to switch a drug or go for surgery, are there other things that we can do to improve our patient care? And the answer is yes. And so with the STEPS tool or with, really thinking about these conversations, that's kind of the first step in trying to improve care. And so with that being said, I'm going to stop sharing and open it up so that I can see everybody, um, and we can have a discussion. Can everybody hear me?
I can hear you.
So what questions, people's thoughts about, trying to change the conversation? Um, Many of you, I don't know if everyone realizes like how debilitating epilepsy can be. If you're not an epilepsy provider, you may not realize that. You might think, someone is seizure free, they can live a normal life. And then you talk to them and they say they live in fear of having a seizure every single day, and it affects them at their job, it affects them socially. And so, even talking to those patients and having that conversation, or referring them to, psychiatry if there's a lot of mood disturbance, even though they're seizure free. These are all things that you still can kind of do to improve the quality of life of the patient. Or maybe that no one has questions, which is okay too. Or that's a good question. So someone just wrote in, do I discuss SUDEP at the first visit? So it depends. If it is a new patient who has had, one-time seizure and they're very anxious and they're meeting me for the first time, I may not, because there's establishment of rapport. But I will discuss it the second time. I'll let them kind of get to know me, get to understand, what our goals are. I'll talk about preventing injury, but I may not talk about sudden unexpected death in epilepsy. And that is I'm not saying that's right or wrong. That's just kind of what I do. By the second visit, I usually do bring it up. However, that being said, if that patient is a new patient to me and they have a long history of seizures, they have multiple seizures, they have nocturnal events, if it's the first visit, I don't care. And if they're not having, if they're having nocturnal convulsions, typically, even if it's one, I may bring it up, and especially discussion about whether to start meds or not, and they don't know if they should, then I would also bring it up. But I know that nocturnal convulsions greatly increase the risk of sudden unexpected death in epilepsy. I know that non-compliance greatly increases that risk. So if there's any of those characteristics at the first visit, it up. But I don't always. And like I said, I don't know if that's right or wrong, but I usually try to gauge the patient and gauge how anxious they are. The other thing is that, if a patient's very anxious and you bring it up at the beginning of the visit, point. And, after Cameron Boyce was a Disney who died now, I think it was 2 or 3 years ago. And what the community said was that we want to know about SUDEP. Even though it's scary to hear, we need to know. And it's worse when someone dies of sudden unexpected death with epilepsy and we didn't even know that it was a possibility. So that's why it definitely needs to be brought up. And that is a great question. The next question. What is your approach to choosing the first? Oh,
I'm sorry for the technical difficulties. I'll just say it right now. My question was about
what your epilepsy safety speech is with patients, if you could maybe help us and go through that.
Let me just see. Choosing the first drug if you suspect patients may not be back for another visit or test. So that's hard. If you suspect that someone may not be back for another visit or test, then I probably would talk about sudden unexpected death and epilepsy and the comorbidities. Each drug if you suspect a patient might not be back for another visit or another test. And you need that they're not going to come back, then you need to give them as much education as you possibly can. You need to talk to them about seizure safety, which I'll talk about in a second. But as far as, first drug, ideally I would want to do a drug that has the least interactions with other medications. So if they have a history of anxiety or depression or suicidal ideation, I'm not going to pick Keppra. If they need some mood stabilization, I may try Trileptal. That's easy to get on. If I don't think they're going to come back, I'm not going to pick Lamictal because that takes 6 to 8 weeks to titrate up. And so I'm going to pick a drug that is easy to titrate, titrates quickly, and has the least amount of interactions and side effects. But I'm also going to talk to them about the fact that they really do need to come back and what epilepsy can mean to them and to their lives. And then I think, CJ, you were kind of asking about just epilepsy safety. And so one thing I talk about with them is that if they've ever had any alteration of awareness at all, that they, especially if they've just had that, they ideally cannot drive for 6 months. So I didn't tell you guys, but I'm new to Ohio. I actually had practiced at the University of Pennsylvania for over 7 years. And Pennsylvania, Delaware, and New Jersey are mandatory reporting states. And so I had to report them to the DMV. So I had to tell them that they couldn't drive for 6 months. Now I'm in Ohio and it's a little bit different. It's not mandatory reporting, but I still typically tell them not to drive for 6 months. And then if they're on medication and they've been seizure free for at least 3 months, sometimes I'll revisit that discussion a little bit earlier. But it depends. So the first is driving. The next is if they've had any alteration of awareness, I ask them if they take showers or baths and tell them that they cannot take any bath alone. They cannot swim alone. And it doesn't mean you can't go swimming, but you need to go swimming and there needs to be a lifeguard there that knows that you've had a seizure. Or if they're going swimming and there's not a lifeguard, they have to be with someone else that is strong enough to pull them out of the water if they were to have a seizure. The other thing that a lot of times is not mentioned is if you have an older adult who has seizures and loss of awareness and they have grandchildren, they also cannot bathe their grandchildren alone. Anyone with loss of consciousness cannot bathe alone and cannot bathe someone else alone. I also talked about, not going on high ladders, working at heights, not working with automatic heavy machinery like an automatic saw or something like that, where if they were to zone out or have an alteration of awareness, their finger, something could happen to them because the automatic machinery doesn't cut off, doesn't turn off. I also talk with them that alcohol, sleep deprivation, and stress can lower their seizure threshold, and so if they are going to drink, that it should be in moderation. I also give them a list of medications that can actually make seizures worse. People don't realize that Benadryl can lower seizure threshold. PM cold medicines, Sudafed, phenylephrine, things like that can lower seizure threshold. Allergy medications with the D formulation. So I actually have a whole list of medications that I give them of what they can take if they get sick versus kind of what to avoid. I think that's mostly everything I say, but I've dot phrases. So I have EPIC. And so, because that would take a long time to write out for every single patient. So I have just a little dot phrase that automatically populates into my notes to make that a little bit easier and for the patients. These are great questions. Any other questions? I apologize for the internet, as I said, in our office. Sometimes it goes in and out, so hopefully you guys could hear me okay. If it turns out you have questions later, I know there's a bunch of fellows on the call or on the presentation. Please reach out to me. I love teaching and am pretty passionate about treating patients with epilepsy. But thank you guys so much for this opportunity and allowing me to speak at your grand rounds this morning. Thank you. I'll end it then. Have a great Thursday. Bye.